Can you please confirm, one, if you can hear me and see me, and two, if you can see the first slide of the presentation as a whole page? Oh, great. Thanks, Mohammed. Right, so we're going to make a start. My name is Loucas Christodolou, and I'm a consultant pediatrician with interest in pediatric neurology. So these, I'm sorry, I thought all of you will be new to the to this postgraduate certificate presentation. So I'm doing a presentation that I delivered last year, but I think some of you might have been at this presentation previously. So I do apologize to those that who are here from last year. However, it's a very interesting presentation, lots of very different videos that it's always good to get a refresher. So we're gonna make a start. So this is on differential diagnosis of epilepsy in children, and we call it fits and funny turns as a term to show this differential of all these paroxysmal events that can happen and can be confused for epilepsy. I mean, some of them are seizures, but not in the context of epileptic seizures. So let's see the objectives for this presentation. So today we're going to discuss some of the definitions in epilepsy and also the baseline, let's say, approaches and evaluations. So I'm not going to get into extreme details, of course, at that. But the main aim is to develop some awareness of the rich variety of these non-epileptic events in childhood. And then we'll see lots of videos and have fun. Now, the most important part of this is the interaction. And please use the chat for that. I'm going to be looking at it constantly and commenting on what you guys say. So what is a seizure? So it's defined as a stereotyped episode of sudden onset that manifests as a disturbance of consciousness, emotion, motor, sensory, autonomic function. So several things, but due to an excessive discharge of cerebral neurons. But to be epilepsy, it has to be a chronic condition with a tendency for recurrent provoked seizures. And typically we say they have to have more than 2 seizures because up to 5% of the normal population out there can have a general tonic-clonic seizure, for example, in their lifetime, but not necessarily have epilepsy. These should not be febrile, should not come under the umbrella of neonatal seizures because not all of those end up being epilepsy, and not a single episode of status epilepticus. So, and another important message is you don't have to rush to diagnose epilepsy. In the UK, we, at some stage, 30% of the children that were on anti-epileptics for epilepsy did not have epilepsy. It's gotten much better because a lot of specialists have been involved in the diagnosis, and it got up to 94% positive correct diagnosis. Still room for improvement. And the most important part, because we don't have perfect tests, is a history. So the important part of the history is before the event, during the event was happening, and then after the event. And also timings, like is there a particular time of the day? Is it a nighttime event? Is it early morning part? And so on. And this will help to narrow down. And then we have an acronym called DESCRIBE, which I'm going to explain at the next slide. Family and social history also extremely important. If the history is not available, not reliable because it's from a third or fourth person, or not consistent, it's better to observe the natural history than rush to a diagnosis again. So what is DESCRIBE? So basically, D stands for description of the episode. And this is really important, but also it's the most difficult thing to do. Like even medical professionals, we cannot really describe accurately an episode. Video, of course, would be the gold standard. epileptic or non-epileptic, and this is what I'm going to be asking you guys to comment later on when we see the videos. And it's just a quick comment. There's no right or wrong. Just when I'm showing you a video, just throw in the chat if you think it's epileptic or non-epileptic. And then the S, the other S stands for seizure type. And if you can't define that, the second S is if it fits into an epilepsy syndrome, for example, absence seizures and so on. And then the C would be a cause if we think it's symptomatic secondary to something else, like an intracranial mass and so on, or if it's idiopathic generalized epilepsy, and so on. And then the R and the I for relative impairment and behavioral, emotional, or educational problems. I have to say apologies for the background sound. I'm in a neurology conference actually, and I had to come out to do the presentation. So I'm sorry about people walking around and the background noise. And then also we always have to ask the question of what else could this be? Make the case for epilepsy, but also against, and then have a differential diagnostic list. Be aware of the variety of non-epileptic events of childhood, and we're going to tackle this today. Now, any investigations helpful? As I said earlier on, there's no perfect tests. There's almost no test which absolutely confirm or refute an epilepsy. 10% of normals would have an abnormal EEG. 50% of what considered epileptic patients would have a normal first EEG, but the yield would increase. So after the second EEG, it would be 65%, 85% after the third. But if you do a sleep EEG, that would increase even more. And then, of course, the gold standard is considered to be the video telemetry, but then it's gold dust. How do you get that? Let's talk a little bit about EEG very quickly. So indications would be if you have more than one seizure, new type of seizure in a known child, epileptic child, aphasia with behavioral problem, history of frequent loss of consciousness, poor history or no witness, but recurrent episodes, single focal seizure at any age, and then fixed neurological deficit following a seizure. It's not helpful when the history suggests fainting, so we do sometimes for syncope, for example, and then it creates huge problems. Single generalized tonic-clonic seizure, again, not necessarily needed to be done straight away. Symptomatic seizures, children with developmental delay or following typical or atypical febrile convulsions. When to image. Now, sorry, we're going to have time for some questions later on in the chat, and we'll address that. So imaging, let's talk a little bit about imaging before going to the videos. We image all children in the UK under the age of 2 years if they've had seizures or they're diagnosed with epilepsy. Localization of symptoms, so if you have focal neurology, so based on semiology, examination, EEG, or in syndromes such as FECS, so focal epilepsy with central temporal spikes, head injuries, etc. The other thing is if you have a specific syndrome that you think is arising from a specific area like temporal lobe epilepsy and so on. Developmental delay or regression, intractable seizures, so syndromic with atypical course, change in seizure pattern, single episode of status epilepticus, especially if it's very prolonged, and then if they present with new onset acute neuropsychiatric problems. And then finally, make your diagnosis as detailed and as coherent as possible. Well supported is likely to be correct. An epilepsy syndrome is a good goal to have, and then beware of any inconsistencies. So for example, if you diagnose a patient with absence epilepsy, but then you do an EEG and it's normal, it doesn't show the 3 hertz per second, then that's inconsistent. So just revisit that diagnosis. So we're going to see some paroxysmal events now and some epileptic events. And I want you to be commenting when you see the video if you think which one it is. And if you can comment on what do you think it is. So why is it important? 4 out of 5 children presenting with paroxysmal episodes or attacks or fits and funny turns, anything you call it, do not have epilepsy. So a significant, like by my vast majority. And we'll see some examples. So let's start with this one. Hope the video will play. It's a very old video, this one, really old. So this guy had a head injury, and then you can see already he started having myoclonic like jerks. So a lot of people would describe that as twitching, as tonic-clonic. You would then proceed to say it's generalized. There's lots of people on top of him, which I don't think is helping him that much. Apologies for the background noise, but there's lots of people coming out from. But if you could hear the commentators, they are also very kind of stressed as to the duration of this and how long it's going for. So if you can put in the chat, do you think this is epileptic or not epileptic? There's no right or wrong, just throw anything that you think in the chat. So May says not epileptic. Tawanda, not epileptic. Apologies if I don't say the names correctly. Hamad, not. Good, so I'm getting lots of responses there. So guys, so those who said it's not epileptic, what would you describe that? So Hamad says traumatic. Anyone else? No right or wrong, just throw anything out there. Due to hypoxia from the head injury, Hamad says neurological, Morales says secondary to trauma. Excellent, so let's go and see. So post-traumatic seizures, Dr. Iman says epilepsy. So this is interesting. We're gonna see now which ones are more associated with epilepsy. So if it's immediate post-traumatic seizure, they are defined as seizures occurring within 2 hours of the injury. Early post-traumatic seizures is a day to a week of the injury, and then late traumatic seizures will be more than 1 week after the trauma. And this is the most likely one to be a poor prognostic factor for epilepsy, developing epilepsy post-trauma. The immediate and early ones, they're thought to be a direct reaction to the injury stimulating the brain. But the late seizures, there's lots of theories, and one of them is damage to the cerebral cortex because of, let's say, the bleeding and then the iron deposition of the blood, or excitotoxicity from glutamate release, which is an excitatory neurotransmitter, as you know. So let's move on and see this video. And you can comment, epileptic or not epileptic? No right or wrong, just throw it out there. So look how he came out of it, and I'll play it one more time. So it looks like generalized tonic-clonic, asynchronous. He's not responding really, but then he comes out of it. He looks a little bit confused, and then he's talking to whoever is standing next to that. So Mohammed and Tawanda says not. Murali also not. May says not. Good. So any ideas what this can be, guys? There will be more clues at the next video. But if any ideas, aha. So May said something very important there, that he's faking it. Mohammed said infectious as well. Anyone else? And Weil says not. Any ideas, Weil, what this can be? Aha, Morales says hysteric. So let's see the next video. So this is a set of videos. It's a big clue there. So lost consciousness, but no movement. This guy dropped, and then you can see some discoordinated clonic movement there. This guy just dropped and lost consciousness. This guy posturing, bilateral posturing, tonic, and then tonic-clonic. This lady, so quite, you can see generalized, almost like tonic-clonic. However, it's a little bit discoordinated. So you can see why someone will say, you know, are they with non-epileptic events? We don't call it pseudo seizures anymore. So lots of videos, and this guy immediately up, but looks very confused, like what's going on. So actually, guys, what this was a group of German medical students, and they got them to do a Valsalva maneuver. So hold their breath and then squat up and down. And then basically they induced something. I don't know if you know by now. I gave you the entire clues there. Any ideas of diagnosis here? So you can see the eyes of this guy also, they rolled backwards. It's generous tonic-clonic movement or kind of moving the head as well. So what this was syncope. So reflex syncopes and feigns. So what is syncope? It's a sudden loss of consciousness and postural tone associated with a cut of energy substrates to the brain through a decrease in cerebral perfusion or drop in oxygen content. And it can be due to lots of causes. As I said to you, they induced it in this cohort by making them do the Valsalva maneuver and like hold their breath and squat up and down. So the description of what people say they have is lightheadedness, progressive loss of tone, emotional stimuli or stress, and then standing posture can also lead to that. May occur in sitting or supine position as well. It may have an abrupt onset, and this is important. You can have, in 10% of syncope, you can have incontinence, so they can wet themselves. It doesn't mean they have epilepsy. And in 50%, they can have clonic movements. So very important not to label someone epileptic just because they have tonic-clonic movements or plus they wet themselves, for example. It may have an abrupt onset as well, but some of these in the cohort were slightly more gradual. Vasovagal attacks can be familial, and then hypoxia may induce a seizure, but also vice versa, the seizures or other things like cardiac arrhythmias can result from epileptic discharge. So that's why it's very important always to do an ECG in all of, not just syncope, but in all of the patients that present with a seizure. So let's move another video. So this little girl is having a finger prick for a blood test. And you see she's happy, she's consenting for it. She gets upset. The mother says, don't worry, don't worry. And then have a look at her face. So her lips are turning blue, almost black. She's quite pale. She's now posturing. She's lost consciousness. If her hand was not being held, both arms would be posturing like that, like very tonic. The whole body turned kind of tonic and postured. And then she's remains tonic for quite a significant amount of time. I mean, this to a parent would look like their child is dying. And then it looks like she's unconscious or sleeping. Some mouthing movements. And then what I said earlier, it's very important, not before and during, but also how she's coming out of the episode. She's straight back into her normal self. So May says breath holding due to excessive crying. Amal the same, morally, vasovagal syncope. Any more takers? Tawanda says vasovagal. So it's 2-2 so far. It's a good competition there. Anyone else? The winning point. Right. No more takers. Let's go and see what it was. So, breath holding spells. So this was a breath holding episode, extremely typical in a child that has a painful stimulus. And what they are, so they occur in 4% of children less than 5 years of age. And we tend to separate them into two categories if we want to be pedantic. Cyanotic breath holding attacks and then pallid breath holding attacks. The pallid is more linked to a reflex hypoxic syncope or reflex anoxic seizures. So you can see that both groups were very correct in a sense. And then we'll see the cyanotic breath holding attacks a little bit more in a bit more detail. So fright, pain, anger, frustration can be triggers. The child cries vigorously, holds the breath in expiration, and then intense cyanosis can occur very quickly, loss of consciousness and limpness. It may have associated stiffening, as we saw in this child. There was a lot of posturing and stiffening. If there was an EEG attached, and this is solely for research purposes that it was, so we don't usually, this doesn't need an EEG. You will see tracing with bradycardia, but oxygen desaturation and reduction in cerebral blood flow basically increases the intrathoracic pressure and decreases the venous return, and this is the pathophysiology. It's a benign condition, entirely harmless. The parents freak out and they think their child is dying, but a lot of reassurance and a lot of education is required. The only time we need to do something is in the next group. So the pallid breath holding attacks. So they may coexist with cyanotic. So you get this extreme pallor in addition to this perioral cyanosis. And it's precipitated by adequate stimulus, usually pain, as in this case, loss of consciousness, minimum or no crying in these cases, but they get this intense marked pallor. They do get stiffening. They do get, if you attach, let's say, monitor on them whilst they're having it, they get a period of asystole. It's a form of cardioinhibitory syncope. And then if there was an EEG, again, exclusively for research purposes, attached, you will see flattening of the trace followed by slow waves. Again, there's no indication for doing EEG, but what there is indication to do is an ECG in this specific group, the pallid breath holding attacks. Just in case, because it might be associated with arrhythmias. And this is the anoxic seizures. We talked about all of that, so I'm not going to go into the detail of that. But it's just, if you want to be pedantic about the extreme details, is what happens during that is bradycardia less than 40 or tachycardia more than 150, a period of asystole, and then they can get drop in blood pressure as well or venous pressure. Right, so let's go and see. Again, this is the pathophysiology. So low perfusion usually due to cardioinhibitory mechanisms mediated through the vagus nerve and vasopressor mechanisms. Cyanosis develops rapidly because of the intrapulmonary right to left shunt, and then rarely is due to primary cardiac events. That's why we do the ECG. Now, if a child has epilepsy, they could get anoxia during a seizure, and they could get cyanosis and pallor and so on, but that's different. That's if they're already diagnosed. Oh, sorry, Mace, you say there's no voice on the videos. Can everyone else hear the voice on the videos, the sounds? Okay, sorry. Mace says it's back now. Good, great. So one of the theories for sudden death in epilepsy is from anoxia during seizures, but there's lots of other theories. Now, this is a great video. Have a look at these guys. This young chap has just gone to sleep, like literally gone to sleep. And this is what he does. So I don't know if you can hear the sound, like how vigorously he's banging his head against the headboard. So that's his mother just turns him around, repositions him, puts a pillow, and that's him. He goes back to sleep. So Morales says, no, I'm not sure if Morales, you mean the sound earlier from mine, or if it's epileptic or not epileptic. So he woke up, looked at his mum, and then he fell asleep again. And as soon as he falls asleep, he's doing this fry noise. And then he starts again. Yeah, quite powerful headbands there. So epileptic or not epileptic? First part of the night. So Allah Hassan says not. Mai says not. Anyone else? Allah says it's hysteric. We'll look at that, Allah, and the good. If no more takers, let's see. So basically, this is one of the. So Hamad says also not epileptic, and it's the way he puts himself to sleep. Some children do, but not this specific one. We're going to look. So there's lots of paroxysmal disorders of sleep. One of them is night terrors that you all might know, and they're common from 18 months to 5 years of age, and they're usually in deep sleep, but in the early part of the night. But this specific one used to be called jactatio capitis nocturna, which is at the onset of sleep. But now there's a different name, rhythmic movement disorder. But other conditions will be nightmares, somnambulism, or sleepwalking, hypnagogic phenomena. So whilst you're going, as soon as you go into sleep, and you can get these brief auditory or visual hallucinations. And I'm sure, I don't know if you guys, any of you had this feeling that someone is talking to you, or maybe you talk as soon as you go to sleep, or you do sudden movement, you don't know why, you are not controlling your body. And then other abnormal movements in sleep include restless legs. Another part of the paroxysmal disorders of sleep is narcolepsy, and narcolepsy is associated with cataplexy, and we're going to see some examples. And then other symptoms of hypersomnia as well. Now, this specific headbanging was this jactatio capitis nocturna, which, as I said now, is called rhythmic movement disorder of sleep. And it's a neurological disorder. It's not hysteric. It's not how he puts himself to sleep, but it's neurological disorder characterized by repetitive movements of large muscle groups in non-REM sleep. Early childhood is when it occurs, and then it diminishes with age. Often associated with other sleep or mental disorders, so like anxiety, for example, something happened wrong, or sleepwalking. And other subcategories would include bruxism, so the teeth grinding, like when they do it, then you can hear the teeth grinding really loud. Thumb sucking, hypnagogic foot tremors, rhythmic sucking. So lots of common things, but it could be associated with that. Now, it's benign, but it's pathological if it's markedly interfering with sleep, and then the child cannot function the next day, or a significant impairment in daytime function, or results in bodily injury. And if we needed to treat, then a small dose of a benzodiazepine, such as clonazepam, can be used for that. And then have a look at this video. So you can see one side of the body started as very tonic and posturing. This is like almost like fencing posture, and then this hypermotor behavior with screaming. And this is the early part of the night, which is part of the history, which is extremely important because it can guide you to the diagnosis. So sorry, it says night terror. Anyone else? I'll play it one more time whilst you guys say some answers. So mine says it's not epileptic because it's a night terror. Anyone else? It's difficult, isn't it? It's very difficult. So let's see what it is. Oh, let's go back. Sorry. So these guys, it's a case actually of frontal lobe seizures. Other name for it is hypermotor seizures. And it happens in the first part of the night. In this case, you can see they take this typical fencing-like posture, but also this, you can see it's tonic and then alternating kind of, I don't know if you can see my cursor, but the right leg with the left arm before this hypermotor incident. Now, you're absolutely right that anyone would say, for example, this looks like night terror, but with the history, a good history and a video, it's really helpful to get to the diagnosis. And then, of course, the EEG will be abnormal as well. Now, the next one. So this is a teenager. He woke up in the morning after going out with his pals the night before, came back 3 o'clock, 4 o'clock in the morning. Mother woke him up early and gave him some cereal. So very subtle what happened there. I don't know if you noticed it. His mother is wiping the mess. He gets very upset and then he's trying again to eat. He's he's very upset that he's being videoed, but it's the only way basically to pick on these things. So very upset that this hip thing happened again. So I don't know if you saw this very subtle myoclonic jerk, basically. And then another name for this is, we call it flying cornflakes. So epileptic or not epileptic? What do you guys think? Just throw what comes to your mind, like the first thing that comes to your mind. So mine says epileptic. Any ideas of what type of epilepsy? Eh? How much says not epileptic? So my myoclonic jerk is a description for it. The name for that specific is not far from that. So it's juvenile myoclonic epilepsy. Yeah, JME. Right, let's see this one. Now, this is a very sad story. So this girl had, oh, mine says focal epilepsy. Okay. Doesn't necessarily need to be focal. Right, so this girl had a very sad story. So she had group B strep meningitis, quite catastrophic when she was born. And this is the outcome. And I mean, you can see that this is obviously epileptic. Yeah, so you saw that sudden flexion, and she knows that something is going to start. So she's calling her mum, and now she's posturing. Yeah, right arm, right side leg, it's becoming tonic. And then again now, she very sudden, very abrupt drop and flexion with posturing of the arms as well. And she gets upset with it. She know it's because it's irritability. And then she recovers, but then happens again. It was very subtle there, but it happens again. So this is an example of, an epileptic condition and generalized epilepsy in her case. And it's seizures, basically post-group B strep neonatal meningitis. But of course, you have a very wide differential in any child of this age that has flexural drops or jerks. If it was a very young baby, you would say, okay, it's infantile spasms. Another thing is Douce syndrome, which used to have another name of myoclonic astatic epilepsy. but also metabolic conditions can start like that. They can start that as something that looks like a DUS syndrome and then develop into things like Batten's disease, which is the neuronal ceroid lipofuscinosis. Now, this girl, if you hear the sound, you might want to close your ears because she'll be screaming a lot. I just reduced the sound a bit because I'm in a conference center as well. So can you have a look at her eyes, like how they open and shut? Then she's mouthing. Then she has this inconsistent. So left arm is moving. The right arm, because it's being held, is not moving. Then she's screaming, but she's looking at her mother who is holding her. So epileptic or not epileptic? Sumaya says not epileptic. Ashford not epileptic. Morales says epileptic. Maya says her hand should still move even if held. Mohammed says not epileptic. But also, can you see, guys, how inconsistent the movements are? They're not like symmetric. There's no pattern, like specific pattern that you would identify. And this is what you guys said earlier on for the other case, a case of non-epileptic events. So it's called psychogenic non-epileptic events. It used to be called pseudo-seizures. We don't call it like that because they don't like it, the patients. They get really upset if we say, oh, faking it or, making it up and so on. So the term non-epileptic seizures or non-epileptic events is being used. Very frequent in adolescents, especially girls more than boys, but children, it's been reported to children as young as 4. I've never seen one at 4, but it's in the literature. It might have this apparent intractability. So whatever you do, they will do it. And the difficult to distinguish from epileptic events. So one of you guys said epileptic, and you can tell. So Morales says epileptic, but you can tell why it's difficult to say. It may mimic any type of seizure, and they end up having this. She was attached to EEG, basically, and video. So she ended up having video telemetry because you have to reassure the family so that they don't keep on, they don't present all the time constantly and then utilize resources. The movements are not typical, clonic, uncoordinated, semi-purposeful, violent expression and not stereotyped. They are responsive immediately after the episode. Some of the episodes can be very long, and the average duration of an attack can be 5.6 minutes. So it's quite a long time for a parent to not, see their children doing that. And then if they have an EEG, a non-paroxysmal EEG, prolonged video EEG recording is helpful just for reassurance and to stop them from either doing it or from presenting constantly. Now, this young lad, so one is two pieces of information. One is his cousin is making him laugh during this video, and his teacher says or complained to his parents that he's sleeping constantly in class. So I'll play the video and you tell me what you think. So he's laughing and then dropping. So it's almost like loss of tone, full loss of tone when he's laughing. It doesn't help that his cousin is constantly making him laugh. So any ideas, epileptic or not epileptic? And if you know what it is, it's good to put it out there. So I have Morales says not, Mohammed says not. So not. Usually, absence seizures, they say that they are daydreaming, but it's very short duration. In this case, the teacher said that he's been very sleepy, as in unable to rouse him. He's sitting down, sitting down on the chair. Morales is due to breath holding. So anyone else, any ideas what this can be? In the context of one slide I had earlier on. So if you think about the excessive sleepiness, could be described as narcolepsy. Well done, Mai. What is associated with narcolepsy that we said earlier on? So narcolepsy can be associated with cataplexy. So in this case, it's cataplexy, which is sudden brief loss of voluntary muscle tone triggered by strong emotions. And in this case, it was the laughter. Commonly associated with narcolepsy, as we said, the attack is brief, few seconds to a couple of minutes in waking hours, and it can be very mild. So some patients might have just drooping of the eyelid, for example. So it can be extremely subtle and very difficult to catch. So history would be extremely important. In the severe forms, you have a total body collapse. And then the caveat is that usually it's not a form of epilepsy or severe epilepsy, but it can occur in association with other conditions like Niemann-Pick type C disease, Prader-Willi, Wilson's disease, stroke, MS, head injury, and encephalitis. Now, of course, in these other conditions, you will have a lot of other pathology and they would have that as diagnosed. There's no medication or cure that would make it go away. You sometimes give stimulants for excessive narcolepsy, but also it's important to good sleep hygiene and help with sleep. Stress management is important, and then avoidance of triggers. In extreme conditions, they tried sodium oxybate for that. Now, look at this video, and a lot of you will recognize this. So he's watching TV. Interestingly, his father is next to him, seeing these movements, totally not stressed about them. She continues feeding him. So any ideas? Is this epileptic or not epileptic? It's very sudden, brief, coordinated, jerk-like movements. Whilst you're thinking, I'll play it one more time. And just throw anything there in the chat. Epileptic, not epileptic. Mace is not epileptic, Morale not. Any ideas, guys, what this can be? Mice is tics. And that's the correct answer. So what that takes, so repeated, individually recognizable intermittent movements that are almost always briefly suppressible and are always, or usually, associated with awareness of an urge to perform the movement. So they have this build-up and they need to do that movement. Tics manifest as sudden, brief, intermittent movements in case of motor tics, or utterances if it's vocal or phonic tics. Now, unlike dyskinetic movements or dystonias, tics do not occur during sleep, so they stop during sleep, but also they're much briefer, much faster. Hamad, you say difficult to see, did you mean the video or difficult to tell if it's tics or not? You're right, that is difficult, but the history, that's why I said the history is extremely important. So when do tics occur? When are they most kind of observed? Is when the child is focusing. So if they're watching TV or if they're reading a book or they're on their iPads, I mean, the younger generation, that's when the tics are worse and much more frequent. So the other thing is it shouldn't affect development. They should not regress. They should not have, all of those things that you get with an epileptic disorder. So yeah, it might be difficult to see if you just see a video, but in the context of the video and the history, you will be able to comment. I know, Hamad, it's about the case, but I hope I have answered that. Now, what's the biggest differential here? So if they have tics, you want to know if they have Tourette's. Now, if it's transient motor tics, and transient, we mean basically duration of less than a year. So they can go for quite a long time. And the advice I give parents is ignore it. Do not pay too much attention to it, to not try to stop them, because that will make the child more aware and then they do more of it. However, if the tic is continuously going on for more than a year, plus it's a complex motor tic, so a combination of groups of muscles, let's say eyes, then the shoulder, then the leg, and so that's different. You have to investigate a bit more. Same with if it's motor and vocal tics, plus the duration, then you need to look into if they have a Tourette syndrome, for example. Now, this case, I'm sure a lot of you will be able to comment if it's epileptic or not epileptic. This is a newborn in a baby unit. Well, soon after, but. And just to give you a little bit more on the history, this is constant, like there's no respite for this baba. Really sad. They tried anti-epileptics and they didn't work. And you can see there's some characteristic facial features there, but also this intense, persistent, tonic, clonic, eye movement, posturing, all of this. Now, mine is infantile spasms, but it's constant. It's like, it's not a brief duration or clusters of it. This is constant throughout the entire day. And it's something called pyridoxine deficiency. So they will not, some of them, let's see actually, yeah, I have a slide. So the classical one occurs within hours of birth with irritability, respiratory difficulties, flaccidity, resistant to conventional anti-epileptic drugs, but will respond to IV pyridoxine. The atypical one, seizures can occur up to 3 years of age, initially may respond to conventional anti-epileptic medications, but sometimes they could get even prolonged seizure-free intervals. But again, without pyridoxine, once they have the actual seizure, later on, they're not going to stop. And then the contrast to that, how we diagnose it? It's so it partly is the history, and then the EEG, of course, would show this extreme kind of spike and wave and abnormality. Let's go back actually to the video to see. It's a very old video. I don't know if you can. Yeah, it's very poor, but you can see that there's constant spikes and waves, but it's not very clear on the video. I'm sorry, but. And then in contrast to that one, so Hamada, the treatment is with pyridoxine, as I mentioned earlier. So you need intravenous pyridoxine, but a lot of kids will end up in a combination of anti-epileptic medications plus pyridoxine. We had a family that kept on coming constantly to intensive care unit because they were constantly needing intravenous pyridoxine. And then we tried to give parents, and this is not, please do not quote me because it's not published yet. We've written it, but it's not published, and there's no research, like peer review data. But we gave them buccal pyridoxine. So they got the IV ampule, and they will give that buccally, as you do with buccal midazolam. And that will abort the episode and prevent the child from coming to intensive care unit, basically. So, but that was like desperate measures rather than anything else. Now, this one, I have the answer underneath, but it's for you to see this contrast between the other case and this one. So this baby is doing these movements, but only in sleep. And you can tell it's like generalized jerks, and they can be prolonged, they can be long and going on for quite some time. And you can tell if a parent sees this kind of, prolonged jerking, they get really upset, and they were like, they're stressed that this is epilepsy basically, but the history is crucial. So it's only occurring in sleep. The baby otherwise normal, developmentally, normal behaviorally, breastfeeding fine. So benign sleep myoclonus, and it's very common. No need even for an EEG. It's done in this case sometimes. Oh, sorry, I go back. So sometimes it's done if you have parents that are so super anxious, for example, and they keep on coming constantly and using resources. So you might end up doing that. Now, there is a question from Hamad for how long the treatment. So unfortunately, is lifelong. So those children end up needing lifelong treatment. A lot of them, unfortunately, they're so severe that they die from that condition earlier on. Sorry, not the benign sleep myoclonus. The question from Hamad was for the pyridoxine deficiency. Now, so summary, I mean, I could go on, and I have beautiful videos of other things. So I'll show you one actually from my clinic this week, which is very interesting. And he's my second patient like this. Let me find this patient for a second. It's on my phone. I don't have that on the presentation because I just got that in clinic. So I don't know if you can see that. I got consent from the mother to show you that. But this baby has very, very cute. And then I don't know if you can see the chin. So I'll play it one more time. Yeah, I don't know if you could see that chin fasciculation. Oh my, I'm sorry. I don't know. Was anyone able to see the video? Shall I try it one more time? Okay. Hazard wants to annotate the share content. Oh, sorry, Hama. Let me try and play the video one more time. And if you cannot, I'm sorry. It's like a very last. It's not part of the presentation, but I'll try. Can you see it now? It's not in the presentation. It's on the video that's supposed to show me. Yeah, did you see that? Good. Okay. So that we don't have a specific diagnosis. I mean, it's isolated chin fasciculation, but basically it's just reassurance, and usually runs in families. So the father and the grandfather also had that. So I'm going to prove Hazard wants to annotate the shared content. Hazard, can you write in the chat what do you want to annotate? Just because I have to do a closure. Sorry, I'm going to run to catch a train soon. Don't know if Hazard Odi can hear us. All right. So I'll summarize, guys, and then if Hazard gets back to us, So basically, I just wanted to give you a taste of the wide differential when it comes down to seizures or children being referred to us with epilepsy. There's a varied pathophysiology. Not all the paroxysmal events are due to epilepsy. Knowledge of non-epileptic events and epilepsy is necessary. And then for accurate diagnosis, you will need good history, most important thing, appropriate investigations, because not all children need an EEG and not all children need neuroimaging, and then appropriate treatment. And then based on that, we can give some sort of a prognosis to parents as well. Now, I'm happy for questions for the next, let's say, 5 minutes. I'm sorry, I'll have to run for a train after that. But any more questions, guys, you can use the chat. I hope this was helpful. There's lots more non-epileptic paroxysmal events that we could be talking about, but I gave you a taste of quite a few that are interesting and can be confusing or be confused with epilepsy. So I hope you enjoyed it. Thanks, Morales. Good to know. Thank you, guys. You've been amazing. Without you, I would be looking really silly because it's important to have that interaction and discussion. And I know we kind of live in a increasingly virtual world, but that made me feel so much better as well to have that interaction. Great. Thank you. You've been amazing. And I'm happy to. Unfortunately, I tried in the past to share the videos and I cannot because some of them are not, they're still waiting approvals and things like that. But the non-video content, I'm happy to share with Reynold and then he can disseminate. And then if you have any questions that you think about later on, you can again email Rila, and then via Rila, I can get that and answer them back to you. So thank you very much. You've been absolutely brilliant. Yeah. Right.